It's my great pleasure to present Professor Chen from Hong Kong. He's a chair professor and clinical professor with great experience in psychosis studies, from high-risk psychosis to outcome, which is the topic of today. So, Professor Chen, if you want to add something, but I think that...
Well, I'm just honored that Eric traveled all the way from Hong Kong to come here, so it's really an honor to have you here with us.
Thank you. Thank you so much for having me here. It is indeed an honor to be interacting, discussing with you all in this grand setting, and in the last 2 days as well. So it's a conference like nothing I have experienced before. So I am a clinician researcher involved in trying to improve the outcome of psychosis through early intervention and associated approaches. So maybe I'll stand here. Today I would share with you some of the thoughts about looking at what factors influence the long-term outcome of psychotic disorders, a little bit beyond the early intervention period, and then reflecting on how much we know and how much we don't really know. Hopefully, it will identify some area for future research for some of us, and also hoping to invite your advice and discussion in this topic. So the topic would be on symptomatic and functional outcome in psychotic disorders. I have 2 sessions, actually. There are some other outcomes that I will talk about in the next session. So these are the 2 outcomes that I will focus on in this session. Okay, so my declarations. Now, I have been here in Palermo many years ago as a teenager, backpacking. And my memory of Palermo is extremely different from what I have today. And it's very fragmented. It was more like, the railway station, some very narrow streets in which you're almost anticipating somebody will jump out from the shadow, and you have to protect your pockets, and then maybe the youth hostel and so on. So I'm grateful to be able to come back after so many years and see a totally different city from my rudimentary impression. Now, I bring this up because this reminds me of something that we realize after years and years of research, that maybe there are things that we take a particular perspective and context in approaching a particular problem. And then after some time, you revisit the problem, maybe from a different perspective, and it may give a totally different view. So that's something that we want to do. Now, I want to follow Professor Oliver Howies in engaging the audience a little bit with questions. So what do you think is the most common cause of psychotic illness after the first episode? So these are the potential cause types. Now, those who think this is a single episode with a complete remission, single episode with some residual symptoms, repeated episode with complete remission in between, and then repeated episode with some residual problem in between, treatment refractory from the first episode, and then death. Now, those who think this is the commonest, 1, okay, 2, 3, very good, optimistic, okay. And this, single episode, right, that's very good. So 1, what about this? Relapsing with complete remission in between, good. And then relapsing, quite a few, yeah. And then this, nobody, right, and this, nobody. So now, wait, let's look at some data from the, Madras study. So this is the sort of figures that we get. Indeed, from that study. So Madras was the former name of Chennai in India. So they have done some very good work in very detailed look at longitudinal cause of illness. So in that particular cohort, most of the patients would be classified as having relapsing cause with almost complete remission in between. And only relatively few people, 13–15%, have a single episode and nothing afterwards. And then treatment resistance was not that high either. So most of the patients fall into the relapsing group with varying degree of residual difficulties. And if we look at a study in the UK, Nottingham study, where I received my junior training, and more or less similar sort of picture. Most people are in the relapsing, but a lot more treatment resistance. Now, of course, it depends on where you draw the boundary between treatment resistance and some improvement. And of course, you have to look at these details. But I think what is clear is that a single episode with no further problem is relatively a minority, and most of the patients have a relapsing cause of illness. Okay, so this is a recent review looking at all the longitudinal follow-up studies. So the conclusion is that symptoms actually tend to improve in the years following the first episode, but relapse are common. So you're very consistent with the older long-term studies. Now, the diversification in positive and negative symptoms with time is very interesting. Now, this stands in a little bit of contrast with the last conclusion that the predictability of the process, the disease process, increased with time, so that short-term outcome predicts long-term outcome. Actually, both the Nottingham study and the Madras study did some statistics to show that the long-term outcome can be predicted quite well by the short-term outcome. And that was one of the sort of rationale for focusing resources to try to obtain as good clinical outcome as possible in the first few years of the illness, in the early intervention sort of paradigm. So this process of some diversification in positive and negative symptoms with time is something worth noting, because there's a change that may be modifiable, that may determine whether somebody is better or not so good, in the long term. Okay, so some decline in cognitive function and gray matter loss following the first episode. Now, another question to make sure you are awake. So what then in our own mind, in your own mind, actually is the most important factor that determine the long-term course of the individual patients? So is that DNG, dopamine, or genes, or stigma, or individual choice, family support, or treatment delay, the factor that we try to address in early intervention work? Oh, well, you have to select what you think is the most important. I mean, of course, it's all the above. Okay, which do you think is the most important? Genes? Nobody. What about this morning's talk, Isabella? Where's Isabella? Okay. Dopamine? Robin is here. Dopamine, so right. And Oliver has gone. Okay. Huh? Right. Okay. What about stigma? The social impact that actually Tony sort of alluded to a little bit in terms of the insight processes. Individual choice? Yes, good to see a few hands. Family support? Wow, quite a few. Wow, that's interesting. And treatment delay? Oh, a lot. Right. Okay. So a lot of you are in the early intervention camp. There's no need for me to persuade you. Okay. Right. Now, I have no answer to that question, of course. And this slide highlighted some of the key processes that could potentially influence the outcome. I'm always reminded by, when you read popular books about complex systems, one of the things you come across, or I come across, was this dynamical system, chaos theory, of how a slight deviation in an initial condition of a system can lead to very different outcomes. So that's something that I think we have to bear in mind as a clinician. So particularly volition. Is that something that the person has a control of, or is that something that is predetermined? How is he able to persist with the CBT or the exercise intervention? Is that already in the genes or something? That's the sort of question that we are against. But there is the possibility that with self-stigma, recovery style, Tony just mentioned, and Tom McGlashan's sort of observations, and social isolation and engagement. So these are factors that we, as clinicians, we see as potentially modifiable. And we encourage the patient to try, and our team to try to configure these factors in the most optimal situation for the patient, right? And then, of course, in the environment, there's a lot of tools that we have been using, and the intervention team, the families, and so on. So when we look at the long-term outcome of psychotic disorders, it is a whole range of these systems, ecosystem, I call them, evolving with time and through the different phases of the illness that we have to think about. So now, another factor which is not quite highlighted in the diagram before is ongoing factors. We have just seen the environmental and the self-related factor, but what about progressive biological factors? Do we know enough about them? Do they exist? So I see Robin will say that everything was determined by the time you are 1 or something, right? No. Okay, so there is this huge debate of how deterministic your course of illness is. By the time you have your first episode, is everything sort of fixed, or are things still changing? Can you still influence the outcome? And of the deterministic factors, are there other factors that actually act on the brain that we do not yet fully understand? And so these are the some of the things that we have to ask. So what about negative symptoms? Were they there all the time from prodrome, or do some of them appear out of the blue in the middle of the illness or the course of the illness? What about brain atrophy? It seems to happen at a rate that is more than the normal population. What are the processes? What are the factors? Is it medication? Now, of course, with David, we talk a bit about the potential effects of over-medication. That's something we have to be very aware of. And then the emergence of refractory states. So certainly, a fair proportion of patients were not treatment resistant at the beginning of their episode, and they became treatment resistant through the course of the illness. So what are the processes that were involved? So we have some suggestions from the talks on Monday. Is that receptor supersensitivity, or is it other system like the glutaminergic system being set in place and playing a increasingly more important role? Now, I put this picture here to try to communicate something that I realized. As clinicians, we see first episode psychosis, and that is how patients present to us. And we know that that's heterogeneous, but the awareness that I learned over time is that Actually, our first episode, psychosis, is the most similar point in time when we see the patients. And then their course diverged from the first episode. They look very similar when they come into hospital or consultation in first episode. And that is a sort of perspective of us being clinicians involved in psychosis work. That is when they seek help, when they come into contact with the service. But that is the point where the diversity is most masked. So the question is whether we should allow a little bit of time before we sort of make our more detailed formulation and speculate on the potential cause of the illness. Okay, another question. What should be the key outcome dimension in psychosis? Positive symptoms, negative symptoms, functioning, quality of life, or mortality. I remember back almost 2 decades ago when we set up our first episode service in Hong Kong, we have to ask this question because it was about the time where you have to define your, in studies, you define your primary outcome. So should this be positive symptom, negative symptom, or functioning or quality of life? So we spent a long time actually debating between functioning and quality of life. And at the end of the day, we decided on functioning. And here we may actually sort of open a point for this. Actually, functioning is something that is very social. You know, whether your functioning is normal or not, even something like employment depends on your society. You know, in Hong Kong, I still remember one of my patients with severe negative symptoms was very happy in a job as a security guard looking over an empty car park space, the space that is not used as a car park. He was very happy. I think another person will find it extremely boring and cannot hold that job. You know? So nevertheless, we felt that it is a little bit more tangible than quality of life, which is heavily influenced by mood and also again, in Hong Kong, we have homeless people living out under the bridge and so on, and have very good quality of life. They feel that they are free, no restriction of the halfway house, and that's a sort of difficulty we have with quality. Now, and mortality, Oliver mentioned. So of this, we have actually chosen to look at functioning. And of course, we know that functioning is heavily influenced by negative symptoms. And here I want to go back to our original slides about the long-term course. Notice that I have compressed all these outcome dimensions into just one dimension, so your up and down curve, right? And in fact, the situations should be a multi-dimensional graph over time, and that would be very complex to visualize. So here, for the purpose of our discussion, I will try to reduce it a little bit to the positive symptom dimension, and then negative symptom together with functioning would be another dimension to simplify things. Okay, so we have looked at psychotic disorder, realize that it is a very heterogeneous group of conditions. They present, the only thing in common is they present with a psychotic episode. And the psychotic episode looks somewhat alike, and probably more alike than in other stages of their illness. And they have multiple pathogenic dimensions, and then we have chosen to look at the cause in terms of the main dimension of symptom and functioning. Okay, now the relationship between these two cause dimensions is actually very interesting. We assume that symptom and functioning, do you think they are independent, or do you think they are related? So it's complex. They are somewhat related. So if you have very bad symptoms, you can't have very good functioning, right? But on the other hand, can you, and we will go into more detail, there are situations where you may have to consider whether functioning or symptom control is the priority. Okay, so the other thing which is we have noticed is that for some reason, the psychotic disorder that present to us clinically tends to be relapsing. And we have a lot of discussion with the presentations on Mondays and yesterday too. So the reason is not clear. It could be that our current antipsychotic treatment does not address the underlying cause, as Oliver has presented, so we need some new drugs to act more upstream. It could be that treatment, treatment responsiveness progress with time, so that if you have a relapse, then you have the condition become more difficult to treat. And then we have already talked a little bit about receptor supersensitivity. So we don't fully understand, but the phenomena is that they are relapsing. And that is very annoying. And at least for the group that presents with a psychotic disorder. So we then, with this perspective, can break down our unidimensional cause to something like this. There is a background symptom, negative symptom, or residual symptoms, and then there are the episodic relapsing psychotic episodes. Okay, now then we look at what we have learned about what may determine some of these dimensions, the outcome in these dimensions from our data in Hong Kong. So we have actually carried out some study to look at the effect of early intervention. And it's not a randomized control, it's a historical control study. So we look at patients who became ill just before we have the early intervention service, compared to a cohort of patients that became ill after we have early intervention services and follow them up for up to 10 years. So the first observation was that, and by the way, the cohorts were matched in terms of diagnosis, premorbid functioning, and other parameter that we thought might influence the outcome. The first thing was that the occupational functioning, just looking at employment, is better in the group that received early intervention. And a lot of that, I think, has to do with the early intervention service. We were able to avoid hospital admission for a fair proportion of patients. And whereas previously, over 90% of first episode present as inpatient, now we have about half. And you can envisage that with a hospital admission, like 1 or 2 months, you're likely to have lost your job. And then it would be more difficult to find, to return to the premorbid functioning. So these sort of processes, which I think some researchers call a social toxicity. So there was a time when people talk about toxic psychosis, in a sense that active psychosis is bad for your brain. I think people look at whether a lot of glutamate in the brain damages the hippocampus and so on. And that ended up being inconclusive when people look at it. But the social toxicity of losing a job, of damaging your relationship when you are psychotic, is something which we see clinically acting every day. And I don't know whether there has been systematic study of that social toxicity of being in a psychotic state for a long period of time. But that seems to be something that has made the difference with the early intervention service in this case, by avoiding hospitalization. Okay, so this is the sample we look at, 100, about 150 patients in each group, historical control. Now, this is just to show you that they were matched with premorbid occupational functioning and mode of onset as well as the diagnosis. So these are, as far as we can look at, comparable group of patients that are about 1 to 1.5 years apart, just before and just after we had the early intervention service in Hong Kong. Okay, if we look at the functional outcome, not just for the first 3 years when they have the early intervention service, we particularly look at year 4 to year 10 when everybody has standard care. So the early intervention service was only for 2 years in that time. And what we see is that some of that effect that is gained by the early intervention service seems to persist beyond the initial 3 years, and actually it was still detectable at 10 years. So this is quite important because a lot of controversy was about whether the effects of early intervention last beyond the time where the intervention was given. Now here I have to remind you about the context. So we are talking about early intervention service in Hong Kong, which is you may imagine, an affluent city, but with a very low and middle income, or probably low income style mental health service. Okay, so we have a very impoverished service in terms of number of psychiatrists, number of social workers, nurses, and so on. So we are talking about a standard care, the comparison group, that is actually quite deprived in terms of clinical service. So if you look at another long-term study, for example, the Copenhagen study, it is far more difficult for them to find lasting effect of early intervention because their standard care was so good that that there is a ceiling of improvement. And in fact, their standard care was better than our early intervention in terms of case loads. Okay, so the contexts are important. Now, another analysis is to look at this is the course type, functioning course type. These are people throughout 10 years have relatively good functioning. And these are people who did not have good function. The important result is here. So you see, for the early intervention group, more proportion of people ended up in the good functioning throughout sort of trajectory, whereas for the standard care group, more people ended up in the low functioning throughout. Now there's an interesting group here in the early intervention group, in that the functioning was a bit better in the first few years when the early intervention service was supporting them, and then it declined. So there is this group of people who are supported when there is additional manpower and case management, but it cannot be sustained when they are transferred to standard care. But then still a larger proportion of people ended up in a good functioning group throughout the 10 years. Sorry, it's not clicking. Okay, now something we notice in looking at the 10-year data which surprised us was that things seems to be changing around year 4 to year 5. And this is in terms of negative symptoms. There seems to be an increase in negative symptoms for patients around that time. And we are not sure why, actually in both groups, in the standard care and the control group. And that is not something right from the beginning, not from year 1, year 2. And I think that is something I mentioned with a diversification of symptoms in the middle years that is very difficult because most of the first episode studies only look at 2 or 3 years. And when things happen in the year 4, year 5, it's very difficult to get information what's happening. Our speculation, is it because of relapse or the emergence of treatment resistance in those years, would be something that we need to look in more detail. Okay, so let us now turn our attention to the psychotic symptoms trajectory. So that was the functioning so trajectory over 10 years. What about the psychotic state? So the key situation here is, what does relapse situation look like? And treatment resistance, how do they evolve with time? And we already heard from Oliver that a lot of relapse are related to a hypersalient stage driven by dopamine and can be addressed by medication. But with time, some non-dopamine factors emerge, leading to increasing treatment resistance or refractory psychosis. So Oliver there, so just a revision reminding us that there's increased dopamine synthesis there, and that is related to responsiveness to antipsychotics, and patients without an increase in dopamine may not respond very well to antipsychotics. So something else is happening. I think that is the important message from Oliver's studies. And okay, so what does the relapse situation look like? I think these were some naturalistic relapse rate from some first episode cohort. So naturalistic meaning that patients don't come off medication. In fact, they were encouraged to carry on with their medication. So, but still relapse of about 30-40% by year 1, and then increasing to 50% year 2, 3, and by 5 years, the majority of patients would have experienced a relapse. So similar to what David has presented to us yesterday. And if we look at the impact of early intervention, there is no impact at all to relapse rate. So despite our improvement in functioning, we have not been able to reduce relapse. So showing that the two dimensions are somewhat dissociable. And again, you can see that the green line is early intervention, and you just keep the relapse a little bit better than in the standard care group, but it catches up after the early intervention finished at year 2. Okay, so what does a clinician sort of think about this as he is treating the patient? So I want to bring you into the clinical pathway, the mindset of a clinician. Now, when we have a patient who present to us with a first episode psychosis, the first thing I think that we often forget is we want to know really how much psychotic symptoms were there before they developed their prodrome. Now, recognizing that some people, they may have had hallucination for years, and it would be unrealistic, unreasonable to expect that to go away with your antipsychotic treatment. So that is something we often forget, and I think we need to remind ourselves. So what were the baseline before the development of the first episode? And then we have the treatment. Now, with the treatment, we hope to get the patient into remission, that is absence of the psychotic symptoms. And then when patients are in remission, the first episode surface would then focus on recovery, on addressing things like cognition, functioning, lifestyle, and other important dimensions. So that is our clinical pathway. That is how we sort of in our mind, we try to stage how we manage our patients. Now, one important process there is that at the time after remission was achieved, as we were working towards recovery, relapse can occur. And when a relapse occurs, it takes us back to this psychosis stage where we have to treat the patient again. And not only that, a proportion of patients then ended up becoming treatment refractory. So we have this sort of interesting cycles of clinical pathway in which our simple treatment leading to recovery is complicated by a potential short-circuiting, looping back into a psychotic stage in which some patient doesn't cycle outside that stage anymore and becoming treatment resistant. So that is the sort of stages that we are looking at. Now, my next question to you is, for those who have experience in treating a first episode psychosis patient, is after 1 year, if you were given 1 year to treat the patient, what proportion of patients do you think will end up in these various boxes? Okay, or where do you think most patients would be after 1 year in these boxes? Okay, those who think that they were in remission or having had a relapse already, or in a treatment refractory stage, or in a complete recovery stage. So you have these choices. So I won't ask you to raise your hands, but it would be good to try to estimate from your experience a proportion of patients in each of these 1 year after your first episode treatment. And yes, Mata.
I guess my point is, how do you know if they are in remission or recovery? I mean, say, I might like to think they have recovered. I'm thinking about the people I see. But I don't actually know if it's just a remission, because I don't know if, say, in 6 months, yes. Because I would like to say recovery in my experience, but I also know that sometimes 2 years down the line, they might have a small relapse, or a proportion of them.
Right. Okay, so it doesn't matter what happened 2 years. Just cross-sectionally at 1 year. And Martha, you're right, if we use a recovery criteria that we require a 6-month symptomatic remission and good functioning, then relatively few of them will be in a recovery after 1 year. Okay. So now, as a first episode, so clinician, I was thinking that most people will be in remission. Maybe a few will be in recovery. I would have thought relatively few of them will have a relapse, and relatively few of them will be treatment refractory. So that was my sort of thought. Now, the data we get, and that was when data we get when we were trying to look at this issue about relapse and maintenance treatment. We try to recruit patients into a study. My surprise was already 30% of patients have already had a relapse within the first year. And they have, and then 25% of them have some residual psychotic symptom, right? So, but 40% of the patients have no psychotic symptoms and had not experienced a relapse. So those were the sort of patients that we were after when thinking about stopping medication, was the 40%. And we were conservative. We were not thinking about stopping medication for those who still have symptoms or those who already have relapse. And of course, these 5% we need to think of how to engage with clozapine as a therapy. So I don't know, compared to your expectation, whether this is better or worse. Certainly it was a little bit worse than I thought. For the outcome 1 year after the first episode. Okay, so I skip that. Now, the next question is for those patients that were in remission, would stopping medication make a difference to them? Now, those are the patients that are very likely to ask the clinician, can I stop my medication? They have no symptoms. They already have been very compliant for more than 1 year with the medication. And those are the patients that I think we have an authentic question to answer. Is stopping medication better for them or continuing medication better for them? And to try to answer that question, we actually carried out a randomized control study. And it's not just us. Around the same time, a Dutch group led by Lex Wunderlich also carry out a randomized study to address this question. And both studies has by now got some long-term follow-up data. So I want to share with you some of those data. And actually, we observe slightly different outcomes. And I will try to share with you how I make sense of the outcome and then have a discussion with you. Okay, so this is just to remind you of David's talks that there is a cost to maintenance medication, that if we just look at cognition or negative symptom and so on, you have factors related to the illness itself, a trait of the illness, or if you don't treat the psychosis well, the factors are associated with a psychotic state. So medication help that, but does it help the trait factors? In itself, it induces some other side effects and compromise cognition or motivation or something. So it's a very complex situation that with medication, we basically produce a new sort of equilibrium for the patient in terms of the cognitive function and the brain, the state in the brain. So we do not reverse what the psychosis, the psychotic illness has produced, but we introduce another stage in which hopefully the psychotic stage will be under control, but at the cost of some of the side effects. So, okay, very quickly, I want to, at this point, introduce some of the observations we have from patients' own perspective. So I already mentioned that for the first episode patient, we have to remember they're usually young people who has been ill for just one time. And the common belief in our society is that mental illness is a result of stress. And if you remove the stress, nothing more will happen. And so for those patients who have recovered completely in terms of positive symptoms, it is quite understandable. They will ask you, for how long do I have to keep on with this medication? And in particular, I think in Hong Kong, it is very rare that in the transition from active treatment to maintenance, that clinician actually explicitly inform the patients that now you are better, but we are keeping the medication for a different purpose, for preventing you from having a relapse. That is almost, does not happen in clinics. So patient would end up thinking, I'm better now, why am I still taking the medication? That is a sort of very legitimate question. We developed a little rating scale that has turned up some rather interesting results. So basically, we asked people simple visual analog scales, how much do they think they have recovered? 100 is full recovery, 0 is no recovery. And this is the sort of distribution. Very few people feel that they have recovered 100%. A lot feel that they have recovered half and between half to 100. And then we ask them, if you feel that you have not fully recovered, now, by the way, these are patients that are treated after the first episode, so they mostly have are in remission in terms of symptoms, that in terms of psychotic symptoms. So we ask them, what makes you feel that you are not fully recovered? And I think this is very important. Problem with functioning, social and occupational functioning, that's what we expect. These are reasons. And, but there are two reasons that we have not expected. One is that I still have some cognitive problems. Subjectively, I feel that my mind is not working as efficiently as before. Now, this is very important because in clinic, we almost never address this question because we do not have cognitive assessment. It's too expensive in the clinics. And so there is a gap between the clinicians telling the patient, you're okay, you're well, you recover, and the patient feeling that there's still something not quite right in the way my mind works. Now, the second thing which was important is that I'm still on medication. I don't think I'm better because I'm still on medication, even though there's no side effect, but I'm still on medication. So that is how patients look at the sense of recovery. And this is rank. The color means how important they think these reasons is. So notice both the cognitive, subjective cognitive dysfunction and need to be on medication are ranked quite highly by patients in feeling in being the reason why they think they have not recovered. What risk do they think they have of a relapse? And that is after our standard psychoeducation with the relapse rate that I have just shown you, that up to 5 years, like 80% of patients relapse. Patients feel that, most of the patients feel that they have only under 50% chance of having a relapse. Okay, so this illustrates very clearly the sort of problem that I think Tony has mentioned earlier about insights. It is okay, I know about this fact, but do I apply this fact to myself? That is the difficult thing. So I guess another important knowledge we have about normal psychology is the optimism bias. People are usually more optimistic about themselves than other people. So whether optimism bias is sufficient to explain this underestimation of a relapse risk in almost all our patients is something I think to be investigated, or is it something more than just optimism bias? Okay, we talk about the recovery style, so I don't want to think about it. It's something of the past. I just want to look ahead. And in fact, when we ask patients about questions about insight, very few of them will come up with a delusional explanation that it was not an illness, I was under a spell or something. The most common response is not a delusional explanation. It's a avoidance to talk about it. I don't remember. I don't want to remember. I don't want to talk about it. And looking ahead. So that is the sort of sealing over recovery style, which we have discussed. Is helpful to some extent, protect your sense of self and so on, but only insofar as it does not affect your decision to receive maintenance treatment. Okay, these two studies that I will quickly cover, both were randomized control studies. Our study in Hong Kong is a double-blind study. The Netherlands study is an open label study. Now, the key difference, I think it is very difficult to compare different populations, but we have to do this because these are the two studies that has long-term follow-up results. So the key difference between them is that the Dutch study would include patients with low level of symptoms, whereas we require remission. So even a mild presence of a positive symptom, we wouldn't include those patients to try to stop their medication. And the Hong Kong study is a discontinuation study, so we aim at discontinuation. We don't just aim at dose reduction, whereas the Dutch study would do both dose reduction leading to discontinuation. And actually, most patients in their study ended up with a dose reduction rather than discontinuation. So we did that because we thought that is what our patients want. They want discontinuation, they don't just want a dose reduction. And then we both have long-term follow-up. And the other major, I think, difference between the population is cannabis use. I think in the Dutch, they actually didn't report this in their paper, the prevalence of cannabis use among the subjects. I assume it is quite a high proportion, whereas in Hong Kong it's probably a very low proportion. Okay, so we asked the question of what happens when we stop medication in this group. In Hong Kong, we just stopped this group. In the Dutch study, they included patients who already had a relapse or still have some residual symptoms. So now we use a standard RCT. Now, if David is here, we actually schedule a discontinuation time to be about 2 months. And being with some flexibility, we ended up actually having take more than 2 months in the process of discontinuation. And so that is what we find. For people who had already had actually a median of 20 months of maintenance, discontinuation of medication ended up in about 80% of relapse in the following year. So a much higher proportion compared to the control group. Now, I have to also emphasize that our criteria for relapse is very stringent. So we start with patients who have no psychotic symptom at all. They have to rate 0 on the PANSS. And then relapse was defined with even a mild recurrence of a psychotic symptom would be a relapse. Okay, so that is, we use a very stringent criteria. Okay, so that's LEX and the study. Now, they have similar results in terms of a short-term relapse rate. So we know that 1 year of maintenance, if you stop medication, most people relapse. Now, the next question is what happened afterwards? So LEX team follow up the patients for 7 years and find that actually for their patient with dose reduction, 7 years later, their remission condition with functioning seems to be better than those that did not have a dose reduction. So that was a observation that led to a lot of discussion about dose reduction studies. Now, I continue with our data. So we follow up our patients after the RCT when they all have standard care. So they were unblinded, they can do what they want with the medication, in discussion with the clinician, and we follow them up for 10 years. Now, it is important to note that in the open situation following the RCT, both group of patients that initially was in the maintenance or in the discontinuation, both ended up having almost equal number of relapses by 5 years. So those who are in maintenance choose to stop the medication, they have a relapse. Those that were in the RCT who had discontinuation may choose to have maintenance afterwards. So the number of relapses equalized in those groups, in the two groups after the RCT. Okay, so it wasn't the long-term relapse rate that make a difference in the long-term outcome. So what happened if we look at the long-term outcome? We look at the outcome very simply as positive symptoms or need for clozapine. So roughly those who become treatment resistant, and then of those who had suicide was included too. So this group who had a discontinuation at year 2 ended up a larger proportion, significantly larger proportion at 10 years, having a poor outcome. And this is the maintenance group. So we are talking about a decision at year 2, influencing the outcome 10 years later. Whereas after year 2, the management are basically the same. Okay, now put that into context. You remember that patients who enter this study in Hong Kong are in this group. So after 1 year, they are actually the best possible outcome group with no relapses, no residual symptoms. And if we then look at what happened if they stop the medication, and the two groups differ in the 10-year outcome. Now, what if you compare with the rest of the patient in this picture that already had a relapse or still have residual symptoms? That is the comparison. So this is the rest of the patient who didn't enter the randomized study. So they are, at 1 year, they are already not so good, and their outcome is not so good after 10 years. So what it shows is that for patients who initially have a very good outcome, discontinuation actually make the outcome worse and approaching that of the group that initially was not so good after 1 year. So it is as if you have a race of people who are on different trajectories, and those people who initially did well have more to lose out by stopping medication early. Okay, and I think the early is important, because if you stop medication later, say after 4 or 5 years, it seems that the impact is not so great. So we also, now the number in the study is about 180, so it's very difficult to do a lot of sophisticated statistics. We attempted to do mediation, and we find that, yes, relapse is a mediator of the long-term outcome. We estimated the timing of the relapse and find that it is the early relapse which makes the most difference to the final outcome. And this is, we look at patients who were on clozapine. The timing of the start of clozapine would be the yellow line. This is year after the double-blind study. So a lot of people after the double-blind study, within 1 or 2 to 3 years, ended up starting clozapine, and that is not seen in the maintenance group. And then you have some late starter on clozapine in both groups. So this is, the numbers are not large enough for a definitive analysis. There was suggestive evidence that maybe it is treatment resistant after the relapse, the early relapse, that actually mediate the long-term outcome. So these are some suggestions we had at the time of the study, which I think are now supported by other studies. Okay, so so dose reductions, and especially for patients who didn't do so well initially, doesn't seem to make that much difference to the final outcome, but might improve functioning. So that is the dilemma that we have, suggested by Lex Wunderlich's study. So there has been a lot of interest in dose reduction, and David talked a little bit about that. Now the great challenge there, I think clinically, is this, the minimum effective dose for maintenance. Do we have good data to suggest, especially for the individual patient, what could be his minimum effective maintenance dose? And that is quite difficult. And without that estimation, and this morning from Isabella's study, I thought, okay, I thought we will have some answer from pharmacogenetics, but it seems that that's not ready there yet. So with dose reduction, we have that dilemma of what is the minimum dose for the individuals. If we, if we go below that dose, and that is the only time we know that about the minimum dose, is we have reduced beyond it, the patient already have a relapse. So the study by Tapeli sort of is rather alarming. I think he basically showed that a lower maintenance dose after first episode seems to be related to a relapse, and that after that relapse, you already require a higher antipsychotic dose to maintain further relapses. Okay, so I think I run out of time, so let me just go to the recommendation. So synthesizing all this data together, what it seems to be telling me is that, first of all, first episode patients are very heterogeneous, and some of that heterogeneity may reveal with time, and we may have to wait a little bit before deciding what to do with the patients. And then for patients who did really well, they have the most to lose after, if they stop their medication. And for that reason, I would, if they were my patient, I would suggest a maintenance for a longer period of time, like 3 years, before they attempt to reduce and stop their medication. Whereas for patients who didn't do so well and have some residual symptoms, maybe a relapse doesn't they haven't that much to lose on a relapse, and they probably if they really want to stop medication, they probably can stop after a shorter period of time. And then for those patients who already relapse and have refractory psychosis, of course, they are not recommended to have a relapse. That would be some sort of maintenance recommendation. And by the way, I agree with David too, that the depot long-acting maintenance is probably the best option. But the challenge is how to then present that option to patients, thinking about at the same time they have to think about how to make sense of their illness and then to receive a medication in which they would perceive as being more a passive sort of agent in receiving that treatment. That's something which is challenging, and I think all the early intervention services should really give a lot of thoughts to. Okay, I will stop there.
Thank you. Thank you. Great presentation. Are there questions?
Thank you. I've really enjoyed that. I think maybe because I'm based in Nottingham, so we can chat about that later. And also, well, I probably should come clean that I'm neither a psychiatrist or a scientist. I'm an economist by trade, but I am studying neuroscience at King's. And so for me, that was my perfect presentation. And I wondered if you had any figures around the policy on budget, or where you would put the money based on your kind of framework.
Right, so it's in the afternoon. We have a little bit on health economics, on the early intervention. So we can discuss there. Yeah.
Any other? There is one online question. If a clinician wishes to stop the antipsychotic medication of a first episode patient who has been well for quite some time, what should be the duration or reduction in percent of tapering of medications?
Okay, yeah, I think David probably would be the best to answer. But in my practice, and I have some discussion with David too, we actually taper very slowly. Probably taking a year or over a year to each step of the tapering, we would take several months, 3-4 months before you reduce further. And that's the sort of rate I would do for my patient. Of course, it will be very difficult in a randomized study to take that sort of time frame. But clinically, that's what I would do. Yeah.
No.
There's a question.
Right. So in this particular study, it was. Yeah. In this study, the design was 2 months. So the tapering in the discontinuation was 2 months, with a flexibility of another 2 months for reducing the medication. So it's relatively rapid compared to what David you think.
Hi, thank you. I was curious about how often the clients were being followed up with during the study, like in terms of a frequency, but also like how long did you spend with them? And in follow-up, depending on that, are there other studies that look at different frequency rates and different lengths of time and the impact that has on the relapse rates?
Right, okay, so in this study, the follow-up was quite frequent because there was a lot of anxiety about relapse being not detected in the study. So it was 2 weekly contact with the patient and then monthly clinical assessment. So I don't know whether that's frequent enough, but that's the sort of monitoring schedule. And of the patients who enter the study would have access. Actually, we have one of our research assistants was a pharmacist, so would have access to a pharmacist colleague to ask questions about potential withdrawal symptoms or other symptoms during the transition period. And they have access to the research staff all the time. So I cannot answer how much impact it will have compared to a naturalistic sort of discontinuation. That would be an important question. Yeah. So the other thing is, so a large number of patients relapse, right? Most of the relapse were caught very early and were handled with a restarting of medication, often low dose outpatient basis is sufficient. I think only about 10% of the patients in the study ended up needing hospitalization in the relapse.
We have time for a very last question.
Okay, thanks. Thanks, that's really good data, Professor Chen. Just a question that when you look at other studies, the 10-year outcomes roughly seem the same, and most of the gains are in the first 2 years, that there's differentiation with EI in the 2 years, but it's not long-lasting, generally speaking. Does that mean, do you think that there's nothing that's really disease-modifying that we're doing that actually changes the long-term prognosis?
Right. So I think it's a very difficult to say something very definitive. I think our data suggests that there is some long-term effect of EI, but there are some other studies, and I think it depends on the control group support to the control group. And now, actually, we will have a little bit of this in the afternoon session too, in which we actually did an RCT of extending the early intervention support from 2 years to 3 years. So I think the long-term study here, I just mention one more tricky things about interpreting long-term study, is that there is, at least in Hong Kong, a trickle effect of the early intervention, in that the early intervention service actually start off a wave of improvement in the standard care service. So the case management become introduced into standard care service after the early intervention service. So if you are doing a 10-year follow-up, the improvement in the standard care that could have been a result of the early intervention study would have improved the standard care group. So making comparisons quite difficult. So I think from what we conclude, we can see in the improvement there are factors that are lasting and modifiable. There are also factors that are modifiable but not lasting. So if we see the functioning, that group of poor functioning who actually decline after early intervention service terminated. So there are these different sets of factors.
Okay, thank you very much again.